Welcome to this installment of our Pharmacy Experts webinar series. Our webinar series is part of the School of Pharmacy's virtual approach to engage with our alumni and friends to facilitate the sharing of information about new and significant developments in healthcare and pharmacy. I'm so happy to introduce the webinar tonight, which will be a roundtable discussion with some of our amazing School of Pharmacy alumni about reducing health disparities in vulnerable populations. Our panelists this evening each work with vulnerable populations in their communities and have a wealth of practice, experience, and expertise to share with our attendees tonight. So it is my pleasure to introduce our panelists this evening. First is Yolanda Tolson. Yolanda is a 1995 graduate of the School of Pharmacy and is the managing pharmacist at the St. Vincent de Paul Charitable Pharmacy in Madison. Our second panelist is Zhao Yang. Zhao is a 2009 graduate from the School of Pharmacy, and she works as a pharmacist at Aspirus Clinic Hospital Pharmacy in Wausau. Zhao is not able to join us this evening due to a family illness, but she has shared written comments about our discussion tonight, and the panelists will incorporate her comments into the discussion. Our third panelist is Dimi Sokol, a 2013 grad from the School of Pharmacy. She is Chief Clinical Officer at Hyatt Pharmacy in Milwaukee. And it is my pleasure to introduce our moderator for tonight's roundtable discussion, Lisa Imhoff. Lisa works at the School of Pharmacy and is the Associate Dean for Diversity and Inclusion. Lisa brings a wealth of experience and expertise to the School of Pharmacy in the diversity, equity, and inclusion space, and she was instrumental in planning our webinar this evening. Lisa, I will turn the program over to you.
Thanks, Dave. So what I'd like to do is just to hear from each of our panelists a little bit more about a quick synopsis of your practice and populations served. So if we could start with, looks like Yolanda's unmuted. We'll start with Yolanda and then Dimi, if you could follow.
Hello, it's so great to be with all of you this evening. I actually, as Dave said, Professor Mott indicated, I am actually a 1995 grad of the School of Pharmacy. And actually, in addition to, I graduated from the School of Pharmacy. I did a rural externship towards the end of my schooling and then did a rotation, not a rotation, but we went to El Salvador, actually on a medical mission trip before I began my practice, which was primarily in Milwaukee. I worked at a federally qualified health center in the heart of Milwaukee and for a few years, and then came to Madison, and I worked both at group health as well as opened up the Access Community Health Center Pharmacy, which is also the only federally qualified health center pharmacy that we have here in Madison. And moving forward, I actually now am at the St. Vincent de Paul Charitable Pharmacy, and we're the only standalone pharmacy and charitable pharmacy in the state. So I've worked in Milwaukee, Kenosha, Racine, as well as Madison. So I've seen a lot of different patient populations, and I'm excited to share about my experience with the rest of the group today.
Thank you so much, Yolanda. Dimi.
Yes, very, very excited to be here and share my experiences with you all. As Professor Mott mentioned, I am at Hyatt Pharmacy in Milwaukee, which is a locally owned independent pharmacy. We have 21 stores now. I started with them in 2014. My role has been solely to perform clinical services in a community setting, which is a lot of medication therapy management, disease state education for patients in the community. In the past 7 years that I've been at Hyatt, have been able to have that opportunity to build a lot of community partnerships, relationships with the local health departments that we're going to talk about today, to be able to kind of show how pharmacists can impact a lot of outcomes for patients, not just medications.
Thank you both for sharing a little bit about your background and the populations you've worked with. You both have a lot of good experience, so we're excited to get straight into the content and the questions. So I'm just going to start with the first question, and either of you can feel free to take it. So the first question is, an important issue related to care for vulnerable populations is mistrust in the healthcare system, mistrust in providers, mistrust in medications. Can you describe how you're seeing mistrust and how it impacts healthcare among vulnerable populations?
Yeah, I can kind of go first if that's okay.
Thank you.
I feel definitely it's a lot of patients with different cultural backgrounds and not kind of aligning up with the providers. That kind of brings in a lot of mistrust. There is a lot of journeys that patients have gone through in their lives. And when we talk about vulnerable population, it specifically means patients who have who belong to ethnic minorities, people with different socioeconomic disadvantages or specific health conditions. So these patients have had journeys already and certain experiences that has impacted their trust in healthcare, trust in healthcare providers. And I see this a lot in different ethnic groups where there is not enough buy-in or trust in terms of any clinical decisions or clinical decisions specifically to procedures or vaccines or medications that a prescriber could be talking to them about. And we've seen a lot of times when patients would come in and be like, should I be picking this medication, or is that going to work for me, or not coming back to get a refill for the medication? And that kind of goes beyond in terms of trusting the labs and, you know, how the decisions are being made for a lot of patients. So I definitely think this is a huge issue with specific groups. We work, my practice is in Milwaukee, which a lot of us know that is a diversity, different people with different ethnic backgrounds. And I see it every day where there are patients who, you know, who have questions in terms of if they should be, you know, getting a specific medication. I've had specific patients who wouldn't want to go back to a prescriber because they had a clash in terms of being disrespectful or the prescriber not understanding what the patient was believing in, and the prescriber questioned the patient's cultural beliefs. So I think that the difference in belief, the difference in trust between different healthcare professionals and patients is what is basically causing this. But I think it definitely has changed. But there's a lot of work to be done by healthcare organizations and, of course, us pharmacists to be able to build that back up and get the patients on our side. And I know some of the pharmacists have also noticed where, you know, there's specifically the Hmong population, how there are differences as they have grown up. They have seen how ethnic people were treated different than Caucasians in terms of getting immunizations, vaccines, or even schooling, housing, insurance opportunities. So the lack of equity, the disproportionate distribution of healthcare is something that has caused the mistrust among the patients, and definitely something that needs to be addressed. And I'm sure we'll discuss more as we go through other questions. So that's my response.
Yolanda.
Yeah, I think Demi covered a lot of it. I think a lot of times it's really there's a need for the providers to kind of put themselves in the patient's shoes and really incorporate the patient's values and beliefs into the treatment plan. I think a lot of times we have much more of a patriarchal approach where we are trained as the expert or the doctor, you know, they're the clinician, they guide and direct the care. But we have to remember that patients are really the experts pertaining to themselves and how they want their care to be implemented. We need to really include the patient's voice in that. And and really kind of work together to kind of come up with a workable compromise that's going to get patients to where they need to be. And when patients do not feel heard, that's where a lot of that mistrust also that it continues to grow. I think there are historical realities that really, there's a historical grounding where a lot of communities don't trust the traditional Western medical system. In America in particular, African Americans, are sure a lot of you may be aware of the Tuskegee syphilis experiment, where folks were offered free health care, and the men that had syphilis were the disease was allowed to progress even when a cure was discovered, and these men had families, and it was all under the guise of providing free health care. So there have been many times in the American history and American medical system where different communities have been somewhat experimented on, or the truth has not always been told. And so as a result, a lot of communities wait until they're very, very ill before they seek treatment, because they've tried all types of home remedies, and perhaps they're also relying on their religion or other things to kind of heal them. So all of these things create a very complicated landscape and make trust a really difficult bridge to cross at times. So it's just really important to understand that many people have different belief systems, and so when we are imposing our traditional training, and approaching the situation with that lens, it can sometimes impact the outcomes for our patients. So it's really important to keep those things in mind.
Yeah, thanks to you both. I think you did a nice job of laying out that there are multiple factors at play that cause mistrust. It's not a single pronged issue that would cause it, and it may vary among populations. So I think that's great. And Yolanda, you started to touch on my next question. So what role can pharmacists play in improving trust among vulnerable populations? So what are some tools or approaches that either pharmacists or pharmacies can adopt to improve the trust level between vulnerable populations and the providers?
I think communication is the key, being willing to listen in a non-judgmental way, and be willing to have more than one conversation, working with the end goal, and starting with the end goal and then working backwards. So, your blood pressure is elevated. You haven't been getting your medications, your blood pressure continues to go up. I hear you saying that you don't like taking medications, but your blood pressure is going up. So how can we work on together to come up with a solution to help be managed, so you don't end up with a heart attack or some of the bad effects of not taking medications. So how can we work together? So it really becomes much more, you should work more collaboratively with the patient. I think that tends to work better, especially when there is mistrust. I think taking the time to listen and to consider and incorporate what you're hearing into the plan, I think that's really important.
Yeah. Demi, do you have some thoughts?
Yeah, I agree with Yolanda. I think giving patient that space and respect, and making sure we understand that they are experts in their own, culture, and they know themselves better than us is very, very important. So like not pushing ourselves on them or giving them, decision-making power is very, very important. Like, you decide what you would like to do today, or how do you want to go further with this process, or what is your plan in terms of working on your diabetes, or asking those kind of questions and giving them that decision-making power is very, very important. Having cultural humility as a healthcare provider is very important. I have worked with patients who are Rohingya, the refugees from Afghanistan, Iran, Syria. Everybody speaks a different language. Everybody has their own cultural reservations. I thought everybody was similar. Like, if somebody is from Syria, they're probably Islamic, but that's not true. They could also be a Christian. So there is like a lot of assumptions I had in my mind. And I think working in Milwaukee really opened up a lot of thought processes for myself, because I think definitely making assumptions is not something that a prescriber or a pharmacist should do. So having that open mind, cultural humility has really helped me to go in with an open mind and heart, and asking them those questions about, as I said, open-ended questions has really helped in developing that relationship, establishing that trust. The more they see people if even if we don't speak their language, but if we are giving them that space, that really helps us in developing that relationship with them. And of course, working with them as a patient, not as a prescription, is also very important. Like trying to connect with them, asking them questions, and also, of course, following up with them has also been something that has helped with, in general, building up that trust for us. And then, of course, having those patient-provider relationships is very, very important. There is a lot of, prescribers who also can get irritated if they, if you're working with a translator or you're working with them trying to assess them with a translator, it can take longer. And a lot of times prescribers and other healthcare practitioners are used to like that fast pace, but if of course you have a translator in the equation, it does take longer. So having that background and having that training is very important for us also to understand that if you are working with a person who has limited health literacy, it might take longer because you're utilizing visual tools and you're trying to explain it to them with all these little things that you have. And it is normal to be able to take that extra time with the patients who have limitations with language or health literacy or any other areas where we need to touch an extra time with them. So I think that extra attention, support, care, and having that cultural humbleness is something that the pharmacist can really work on to be able to establish. And of course, during the schools also, like a lot of students at the rotation, they're taking a lot of time to, especially with our site, there are students who are working on going out to patients, talking to them, or utilizing translator. I think it's really cool to see how students start their rotation at Hyatt Pharmacy and they're like shocked, and then through the end of the rotation they really get used to on how many different languages we have, how many different kind of patients we work with in a day. It's kind of a day and night when they leave, because day one they're like, oh my gosh, this is too much, in terms of languages and cultures and last names and different kind of names, because a lot of times names can be different too, if people are from different country, and you have to have a very respectful way of pronouncing names, even if you can't. So I think students learn a lot when they come to our sites, and I think the training is also something that really, really helps.
I would also,
Go
one
ahead.
of the, oh, go ahead, Lisa.
Oh, I was gonna say, Demi, it sounds like a really dynamic place where you work. And I wanted to share my appreciation for you talking about, as a provider, you had your own assumptions and you kind of have to check those and leave those at the door. Like that's part of the cultural humility work, right? Is like checking our biases that we might have that kind of lead to the mistrust if we actually act on them. So I really thank you for bringing that up. Yolanda, were you gonna say something?
I was going to say a couple of things. One thing that's universal, regardless of what language you're able to speak or whether you can communicate with someone that speaks a different language or not, one thing that's universal is being able to show that you care. And I teach also with the pharmacist communications class, and that's one of the things that the saying that I started the class with is people don't care how much you know until they know how much you care. So I think if you're truly sincerely putting forth an effort to try to understand and communicate with someone, I think that really comes through regardless of whether you can speak the language or not. The language line and translators are always really wonderful. And again, they do double the time that you often need to take with a patient. But I think also even learning how to work with a translator is important too, speaking to the patient rather than the translator, because the translator is actually just the conduit to ensure that the communication continues, but it's really important to just continue to maintain the eye contact and the relation that's building a relationship with the patient that goes a long way towards building trust. So I think also just being willing to be a little vulnerable as well. I think we're kind of trained in pharmacy school and just in the medical sciences as well about being very precise and very exact, but some things sometimes there are areas where we're making assumptions, all these things that can really impede our ability to connect with patients. So I just would encourage folks to not be afraid of being vulnerable and lead with caring, because it really takes you a long way.
you, Yolanda, for highlighting those points as well. The being the real human in front of the patient versus the expert imparting knowledge on them makes a huge difference. We're going to move into a question that's kind of tied to mistrust. I think it very much actually is. So an issue that is really important right now is vaccine hesitancy. Can you describe what you're seeing in practice related to vaccine hesitancy?
I can talk to like my example of Milwaukee. I look at the map every day, and it's still astonishing to see how the very inner city of Milwaukee is still very low on vaccination rate, even though there's availability and access. Early on in 2021, I was a part of the work group calls for Immunize Milwaukee. And early on, the discussion was around access, right? There's limited access, there's lack of technology, people are not able to make appointments. And then, we went on, there was more access. We set up a lot of mobile immunization clinics where the vaccine was available. There was no restrictions in terms of like putting an appointment, taking an appointment. So technology was not a barrier anymore, but it's still very low. And it definitely comes from that mistrust. So like, of course, still very, very prevalent. People are still not believing in the vaccine. And I think a lot of it ties in with the cultural beliefs, religious beliefs. And we always, like, whenever I'm having a discussion or a conversation with a patient, either they're, from a different cultural background, and they have, beliefs that they do not want to take the vaccine, or religious belief. And I'm being very open about it, that, there's facts, there's science behind it. I print out data, show them the hospitalization rates, show how vaccination versus a non-vaccinated patient, the hospitalization risk is increasing. We talk about their health risk factors, their family members. Of course, certain patients are very, very, stringent and strict, and they're not going to budge. But there are a lot of patients, after having those discussions, knowing, like, they know my face, they know me, they trust me, they have taken medications from our pharmacy. So I think pharmacist is an accessible healthcare provider. They don't need an appointment. They trust us a lot in terms of, if we are advising them about something, they would believe in us. And I think it's just about us having that conversation about COVID testing, COVID vaccination. Testing was still a problem, right? People were like, I don't want to test, it's probably just a cold. I'm like, you should still test, because what if you are positive? You would spread it to your other family members. So I think having those conversations, showing them the facts, has been something that, we have done to address the hesitancy, but it's still pretty prevalent in Milwaukee, sadly.
And I would say that there's a lot of misinformation out there too. Some of the discussions that I've had with folks are, a lot of folks are concerned about fertility. I think there's just a general mistrust of the system, the medical system, also with the government. Some people fear that they're being tracked by the government. They hear from others, that they got sick from the vaccine, and they didn't have any problems until they had the vaccine. So, there's all kinds of different experiences. And I think a lot of communities where there's not a lot of trust of, the system, whether it be the medical system or the government, then they really rely more on their peers and what they're hearing from their community. So taking all those things into consideration and doing what Demi was explaining about, really just sharing the facts, down to your own, your own city or your community. I think that's can be helpful. So it has to be kind of put in context. And so one of the things and one of the approaches that we've taken is really just giving folks time to ask all the questions that they have and really try to answer them one by one. So it takes a lot more time, I would say, to kind of get to the same space that others are. It's interesting because I work also in places like Costco, where we have folks kind of, as soon as the recommendation is released, they're at the door waiting for the vaccine. So we have that extreme all the way to folks that are like, there's no way in the world that I'm going to take this vaccine. There's nothing you can do to get me or to convince me to take this. I'm not putting anything in my body. I'm not going to be tracked by the government. And so then, we start talking about, well, do you have a cell phone or do you get on the computer? Those, you're already being tracked. So it's too late. So just kind of having some realistic conversations about folks and really putting some of the fears, talking through the fears, and then also providing facts to contrast with the myths that they're hearing, and just really taking time to hear them. And interestingly enough, I also work at Costco, and I'm working with folks that maybe for political reasons also don't believe in getting the vaccine, and they also believe, it's interesting, they have the same reasons for not wanting to take the vaccine oftentimes, which is very interesting. But I think the folks that I have been able to, in both cases, when you give people time to talk about what the issues are and what they're really grappling with, it is really amazing to me how many people actually, they've thanked me for listening, and and maybe they were reluctant to get the vaccine. They got it, but they didn't feel good about getting it. And so one of the things that we lead with is saying, we want you to feel good about this decision. So we're not trying to impose our will on people. I think really providing folks the space for their own autonomy and self-efficacy is something that we really want to support. And I think it's even more important when there's mistrust, and history of mistrust in the communities that you're working with. And just to go back to the other topic really quickly, I think one of the other things too, when you're dealing with a community, and it may be a very diverse community, even if it's not a community that you come from, learning how to say at least thank you in the language that is commonly spoken amongst the patients that you have is really a very simple and easy way to kind of make a connection, a bridge to trust and better healthcare together. So that's my.
Yeah, but I'm hearing from both of you, pharmacists and other healthcare providers would benefit from really understanding all these contextual factors that might be leading to vaccine hesitancy. And I think, like you're saying, Yolanda, really just taking the time to answer those questions versus coming down on the patient saying, like, don't you trust the science? And these really kind of, reductionist kind of ways where people don't feel like they can talk. So it really is about spending the time. So I appreciate those points. You both talked a little bit from an individual level in terms of how you deal with vaccine hesitancy. Are there any best practices that you think pharmacists or pharmacies could do to adopt that would help reduce vaccine hesitancy?
I think for us, it's definitely been a lot of the community presence has really helped the pharmacy kind of have the relationship and establish that trust. And this is not just with COVID. I think pharmacies have been trusted for immunizations even pre-COVID, right? We were doing flu vaccines, Shingrix, a lot of immunizations. So patients do look at pharmacies for getting the vaccine. Health departments trust us. So I think for us, what has worked very well strategically is to kind of work with the health departments, work where people are comfortable. For example, Hispanic communities are very, very close-knit, right? They do not like to go to a place that they don't know, they don't trust, they don't recognize anybody. They really like to go to their community center. So there are community centers in Milwaukee, specifically like United Community Center. They're very, very advanced in terms of supporting the Hispanic population. They have schools. We have worked very closely with them to organize several immunization clinics where people of different age groups have come out to receive their vaccine. So I think having those presence in the community, working closely with religious groups has also helped. So we've done it at several churches where the religious leaders would get the vaccine and encourage the whole group to get the vaccine, including pediatric patients as the vaccines come out. So I think setting those examples from the community leaders has been very helpful. Of course, incentivizing has been something that has happened a lot in our state where, the state has incentivized patients. Some people it really helped, some people it didn't really help. So I think there's several areas that we've worked on, and it's slowly moving, but I think the people who are still not ready are going to be a little bit tough cookies to handle, but we're going to keep trying.
I would say just meeting people where they're at. I think Demi kind of touched upon that too, but really increasing our presence outside of our four walls and really
Mhm.
getting out. And so working with churches, in our case, we work with churches. We've had events at community centers where we have offered the vaccine, and we've also had tables where we could just speak to people and provide information. So I think also being willing to have an additional conversation is very key as well. So it's, it's not a one and done, or, if we haven't convinced them, we, um, in a very opposite way, we actually encourage folks to talk it over with their family, go home and talk about it. We provide them with the information, and we answer the questions that they may have. We encourage them to talk with other folks in their family or support group, and then come back. We let them know that we're here and that we will be willing, willing and ready to help them when they are ready. I think that's gone a long way, and we've actually had quite a bit of success with that approach, where we've even had folks that, they even had deaths in their family. They were affected by COVID personally in their families, but they still weren't quite convinced. But because one family member had a positive experience with us, then they told their friends, and they said, after, especially as folks were getting ill in their family, they said, we might as well come in. I'm actually not sure why it took so long, but just being able to have those conversations and continuing those conversations is so critical. So I think, especially in the community pharmacy and in healthcare, a lot of times too, everything's kind of rush, rush, rush. Let's get, on to the next. But really, we really do. You have to take time, be willing to take time, and have folks that are willing or focused on just providing that time. Not everybody may be able to do that, but if there are some folks that you can kind of pinpoint and allow, and I think with the COVID vaccines in particular, with the reimbursement rates as they are, it really opens up some opportunities to be able to change staffing so that you can really have folks that can really spend time answering questions and encouraging folks to get to the yes, and one that they can live with.
Thanks. Yeah, I really am just hearing reducing as many barriers as possible, in whatever way you can, whether that be going into the community, spending more time, encouraging them to talk to family members. It's really about creativity and being a little different, right, than the norm, which I appreciate. Well, kind of building on that, decreasing barriers. We talk a lot about the social determinants of health and how they're important in contributing to healthcare disparities. And you've talked about some of these, but what are some of the main social determinants of health that are acting as barriers to vulnerable populations receiving the care that they need?
I would say one main one is transportation. So
Mhm.
I know Hyatt Pharmacy does a wonderful job at kind of doing home visits and so on. That is not something that we do much here at St. Phineas, but because of some of the grant funding that we've been able to secure, we actually have been able to provide Uber rides for folks to come and get their vaccine, to come and also go home on a free Uber ride. So after we've had conversations, we actually are able to provide the vaccine. So um, it's actually worked out really well for us. Um, yeah.
I agree. I think pharmacies can definitely impact and assess a lot of the social determinants of health that would contribute in their outcomes. For specific examples that we've seen, Yolanda mentioned transportation is a huge barrier, definitely. So because when I started in 2014, I was doing a home visit with a patient, an older lady, was very anxious, very worried. And that example, this whole story just sticks in my mind because of how anxious she was that her ride was late. And she had to be outside the door, although it was freezing cold, because if she misses a ride, another ride probably wouldn't come. So she has to be standing outside waiting for the ride, get to the clinic. Um, and then, of course, on her way back, she told me that she has to wait for another hours for the ride. So she has to be ready if the doctor delays the lab or something happens where she's not outside the door on her way back. It's going to be like another 2 hour wait for her. And that's for a doctor visit. Imagine how things would be if they have to go to the pharmacy to pick up a prescription. And if a prescription is not ready or they have to wait, the transportation person is going to keep calling the patient that I'm leaving and telling her that she has to wait for another 2 hours if she misses a ride. So transportation is definitely very hard for people, especially in Milwaukee, have seen a lot of times where seniors struggle with it. So of course, that is something that we support with trying to get the medications to them. I think a lot of times we're trying to train our technicians working with an organization called Unite Wisconsin to train them on how to become a community health worker, where they're educated on different social determinants of health, trying to learn from patient and not just kind of limiting your conversation to medications. Like, hey, Ms. Smith, your medications are ready. When would you like to get it picked up or delivered? Hey, I'm going to pass this month because I'm not feeling too good. I'll call you guys back. And she hangs up. Versus if the technician's trained, they could have been like, Ms. Smith, what's going on? Did something happen? And then she says, oh, I slipped, I fell, I can't get out of the bed, or, I do not have my copay. There could be so many reasons, right? Or she's worried about saving her money just for her food for this month because she cannot pay the copays. There could be several factors that could have contributed her to say, I do not want my prescription this month, right? So having that training for pharmacists and technicians is very important to assess those factors that could have caused her to say no to her prescription, right? It could be copay, it could be so many other factors. The other thing also is access to food. I think that's also something that we've seen a lot. And as pharmacies, we are a center of resources, right? Where if a lot of times we know what are different food pantries available, we can educate patients. Like one of our UW residents, she was at a home visit for a patient who has diabetes. And of course, all he eats is food that's frozen. And that's because of the access they have. They don't have access to fresh food. Grocery stores are very limited in Milwaukee. If you're driving around inner city of Milwaukee, it'll be shocking for you to see how there is not a lot of fresh produce grocery stores that you would notice while you're driving around. So I think what she did was to give him address of a food pantry was literally a block away from his apartment. So he could actually go there every Friday afternoon to pick up some fresh produce for himself. So like getting people connected with those resources that are available, but they don't know about them, I think is something that pharmacies can do a lot by assessing what are the factors that are impacting their health versus making assumptions in terms of, oh, why couldn't they afford their copay of $1? Or because that's how I started when I was a resident, that, hey, sir, your copay is just $1. Saying that just $1, now I feel like it was so not nice of me because $1 could mean a lot for that patient. So I think just that learning has been very helpful and kind of, assessing those social determinants of health and keep getting that training for ourselves is also very important.
I also have an example with community health workers. Well, there was a program, and I'm actually not sure of the city, but the community health workers were tasked with checking on pregnant women in a particular zip code, trying to work with them to prevent low birth weight babies, produce healthy deliveries. And so there was one mom in particular who had diabetes, and her diabetes continued to worsen. And so they were always, so they were inquiring about, they kept changing her medications and increasing her dose, but it wasn't until the community health worker actually went to her home that they discovered that she did not have a refrigerator to store the insulin. So her insulin was not being, it was not working the way it was prescribed. And her diabetes as a result was out of control. And so also food, there's a lot of food deserts, as Demi was talking about, especially in inner cities and even sometimes in rural communities, which really make it difficult for folks to eat well. And actually, it's expensive to be poor. It costs a lot of money. So those dollars add up and prevent folks from being able to purchase the healthy foods that will provide them with healthier outcomes. And so if they don't have a good diet, then a lot of their health conditions worsen, or the medications may not be as effective. So I think putting the patient in context is really an important thing to do and to keep in mind, because oftentimes we approach the patient with our own experiences and our own our own context, and oftentimes the lived experiences of our patients is very different. So really being open to letting them tell us more and then developing a plan around what we have learned from them. And sometimes they're not going to tell you right away either. So that's where the trust comes in. So it's something that it really all takes more time, but in the end, it pays off for everyone.
Yeah. I think what we'll do, I hear there's a lot of good questions in the chat. So I would like to move to some of the questions now, if that's okay. And this one is from a prospective pharmacy student. So what initiatives or processes do healthcare systems have in place to help bridge cultural barriers such as language? As a prospective pharmacy student, what is the pharmacist's role providing linguistic or culturally sensitive care?
I know that the Civil Rights Act, any pharmacy or healthcare provider that's receiving federal funding is required to provide translation services due to the Civil Rights Act of 1964, I believe. So if you're at the university or so on, those services are provided. I think well, actually, Demi, do you know more about what's happening?
Right. So I'm in an independent pharmacy, but I know health organizations do have, they are working towards, I mean, of course, a lot of diversity inclusion in their teams where they're hiring members from different cultural backgrounds, of course. But then translation services, you're right, Yolanda, are available either in person, they could have a translator at the visit, or they would have a telephonic translator available. In terms of pharmacies, also, it's the same thing where you could have a translator available through a telephonic service also. So that's pretty much what I'm aware of, but I definitely feel that there's a lot of momentum in terms of having that cultural diversity in the teams in bigger health organizations as well.
So I think if you have the power to hire folks, then obviously hiring a diverse staff is very helpful, especially, depending on the community that you're working with. So either hiring a diverse staff or having a staff that is open and willing to learn about the cultural practices and patterns of the communities that their practices set up in. I think that just goes a long way. The language lines are something that's available for most pharmacies. You do have to pay for those services, so that's something to keep in mind. But they are available, as Demi was saying, both through the telephone, and they also have virtual interpreters as well. So utilizing those services, and I think the pharmacy school does a good job of at least exposing some of those options. I know that's something that we explore in the communications class as well. So you'll get a chance to do some practice, and at places like Demi's in particular, you would get a chance to actually try out the skills that you've heard about and seen.
We have another question here. And this one says, you have made a lot of great points in gaining trust from the patient to improve the patient-provider relationship. Wondering if you have struggled or dealt with lack of your trust in the patient, and if this has impacted the quality of care. So your lack of trust in a patient.
Yeah, definitely. Like, especially if you're working on a patient trying to do a tobacco cessation, interview with them, and they leave, you did the whole nicotine replacement for them, they come back, and then you ask that question, and I know that they're not saying the truth or they're not accepting that they did smoke. I think there can be instances where I'm not trusting the patient, but again, we have to be careful in terms of not being biased and still having that, sort of like, okay, I still trust you and I'm still kind of open to a conversation, not letting it influence the way the patient sees it, and still trying to motivate the patient, of course, not manipulation or not, playing with the words, but again, trying to make sure that they do tell you the truth or they do accept that they did have, they did smoke or they did have a slip. So I think even if there's lack of trust, I think we're still support, like I still keep working on having that dialogue, having them trust me so they can disclose whatever they want to me versus hiding things.
Yeah, and I
Great.
think it takes more work to do that because it really, you have to keep working through it. And, you
Mhm.
can have data that shows otherwise. We say they're not doing this, but this is showing up. I mean, you just have to keep having those
Yeah,
conversations.
yeah,
Um,
Yeah, I almost feel like we can't have the expectation for our patients to be
yeah.
perfect, right? Like,
exactly.
I used to work with substance use and mental health, and it's kind of part of
Mhm.
the territory. Like, we're not perfect beings as humans, and
Right.
not every regimen is followed perfectly.
Same thing with a lot of opioid use. I think similar things happen. Diabetic supplies, for testing supplies, there's a whole market in Milwaukee where people sell it. That does not mean that everybody who comes in for an early fill is actually, into that practice. So I think that happens a lot, working with different patient populations, that I think it's more about educating and still trying to work with them versus working against them. Because at the end of the day, we have to support their health needs.
I can also share a quick example. Also, we offer men's transitional housing program, and we have our summer interns working with the residents there. And one of the projects ideas that we had when we first started that developing that relationship with the residents was that most of the men smoked, and so we decided that was going to be was, an area that we were going to tackle and work with the men to stop smoking. And when as we began to visit and we talked with the men, we really realized that the men didn't really have much in their life that was in their control, and that really smoking was an area of pleasure. And, so just kind of reframing how we think about what we see as a problem, and kind of again putting it back into context is just so critically important, because I think we miss a lot when we um, want to just look at that end result and not really think about at what cost. And I think also being willing to ask additional questions is so critical as well. I have another example of there was a patient who she had been prescribed pain medications, and the doctor just didn't feel like she was adhering to. She didn't feel like she felt like she was seeking, exhibiting drug seeking behavior, and so she did a urine screen, and she was approaching her in that manner. And when she did a urine screen, she found that she didn't have the narcotic her in her screen, and um, so the doctor approached her in one way, but my colleague, she went and she talked to the patient and got more information by asking that one additional question. She found out that the woman actually was a grandmother, and she took care of her small grandchildren. And so during the times that she was taking care of her small grandchildren, she held the pain medicines so that she could be alert to keep, up with the grandkids. So it's just a reminder to not always assume, and just again to ask that one additional question. You can get so much valuable information that you can build upon. So I think a lot of times we make assumptions, and it's also just to make, to get through the day a lot quicker, right? But I think in cases where you have a lot of mistrust, it's going to take more time, and you really do need to leave space for a different answer.
Thank you. A lot of good questions here in the chat I'm seeing. I'm going to move to this one here. In your experience, how does care and health inequity among different populations in this area compare to other areas in the state and beyond? You want me to repeat that?
Yeah.
Yeah. So how does healthcare inequity among different populations compare to other areas in the state? So maybe compared to where you all work to other areas in the state, inequities.
So Milwaukee has, of course, huge health systems, right? There's 2 or 3, I want to say, huge health systems that take up a lot of the load for the patients. And then definitely there's primary practices that are smaller, independent practices. So definitely there is access, but I think based of, again, going back to vulnerable population, because of priorities being different, a lot of times patients are not able to keep up with their appointments. And at the end of the day, they're discharged from these healthcare systems because of their no-show rate. And I think that has led to a lot of inequity because they do not have access to transportation. They do not have access to technology or telehealth. Does not mean that they do not deserve health care similar to somebody who has a car or a computer and they can get on a smartphone and have a telehealth visit, and they never miss their appointment. So I think that's where I see a lot of inequity in Milwaukee for sure, where patients lose their primary care prescriber because they had no shows because of their limitations and barriers. So I think that for sure has really caused areas where patients are now without a primary care prescriber, and they end up in the urgent cares to see or to get their medications because they have an elevated blood pressure, and they take it for 30 days and then they go without it for months. So I think that's where the inequity is, that people are relying on urgent cares to go and take care of their immediate medical needs, but they do not have an established care. And that's something that really bothers me. And then also in terms of detox, there are patients who want to go through detox, but there is very limited access depending on where the person is regionally. And I think that's very sad too, because in Milwaukee, it's hard to get into a detox. And if a person is ready, they need to get in today, not 2 weeks later. There shouldn't be a waiting list. So I think that's also an area where there is inequities as far as I have noticed and through my experience.
I would say in Madison, I think we tend to be a very resource rich community in general. I think, but I think there's still the barriers of trust. And also going back to the transportation issue, I think, a lot of our folks are not only just the transportation, but just kind of reacting from moving from crisis to crisis, right? And so, when we have a very precise medical system that, expects you to be at a certain place at a certain time, and you're relying on rides, and the rides only provide you with a certain amount of time to get here or there. I mean, the people that they're kind of being acted upon, they really aren't always in control of their own destiny in a way. And then when they're confronted with by the system and greeted, abruptly, or, like, oh, you were supposed to be, it just adds to bad situation worse. And so it is quite complicated. So even though there is a lot of access, I say, in the Madison community, I think there's still that mistrust. I think, unlike Milwaukee, we really don't have a lot of diverse providers. So that also makes the ability for folks to reach out and trust even less likely. So even though we have a lot of resources, people still may not want to use them because of the previous bad experiences that they may have had. And so that impacts the future decisions that they make.
Yeah, I agree. It's too bad we can't have a long-term approach versus kind of being short-sighted and not be, and like for the no-show rate of, to lose your PCP is awful. And then to go to the emergency room is just the cost. I mean, if you're thinking clearly, just numbers, it doesn't make any sense. So great point. We're gonna close out with some final questions. So you both, I know, do a lot of collaboration. You're collaborating with us, the School of Pharmacy. I'm curious, there's often other community-based organizations and or providers that are providing care to vulnerable populations. What are your experiences working with other community organizations working with vulnerable populations? So how do you kind of collaborate?
We are working with the Milwaukee County Behavioral Health Department to support with specific patients who have behavioral health issues. So I think that collaboration has been really great. It's pretty new. We just did like the contracting and paperwork because it's through Milwaukee County. That is something that definitely is a huge area. And as we were talking about inequity earlier, that is also an area that has really gone down the hill in the last 2 years because of limited availability of psych appointments. So I think that's where we will be working on in this next year, where we'll be able to support more patients and support them with med management for psych conditions.
How about, thank you, Demi. How about you, Yolanda, working with other community organizations serving vulnerable populations?
I missed my internet went out, so I'm sorry I missed the beginning of the question.
Oh, sure. Just in your experience working with other community organizations, collaborating with them to serve vulnerable populations, can you just share some examples or some best practices?
Well, we've worked with the African American Health Network. We've worked with community centers like Goodman Community Center. So we've worked in with community health centers that are in the communities where a lot of diverse patients or diverse populations exist within the community. And we've also worked with groups that specifically work with diverse folks. So I think those are also good approaches to take. Really kind of considering getting to know, just like in marketing, you know your markets, you need to know the community that you're serving and really work to understand as best you can. Understanding that you'll never necessarily be an expert, but just be willing to, that cultural humility really comes into play. And I think it really goes a long way. We've worked with the university also, we work with UW, and we also work with Edgewood, in particular with the School of Nursing, to work both interprofessionally as well as, across communities. We also, where we're situated, St. Vincent de Paul, we're situated next to a grocery market and a laundromat. So we actually have quite a few diverse communities kind of coming and utilizing those services too. So even reaching out, I've gone over to the store, the Mung store, and just, let them know that the pharmacy exists. And they actually had a vaccination effort where they were bringing in, I don't know if the public health department was helping them, but they were bringing in folks that actually spoke Hmong that could work with the community to help make them feel comfortable about getting the vaccine and offering the vaccine. And so they were only doing that one day a week. And I went and said that we're here too, and we can help you as well. And we will also make sure that we have folks that are from the community a part of this so that we can ensure that folks feel comfortable and get the questions answered that they have so that they can also feel good about the decision. So I would just say, don't be afraid to reach out to other communities to help you as well, because I think most people are willing to share.
I agree. And I just want to add another point of working with the local health departments too has been very, very helpful, especially with the vaccine, initiatives that we've been trying to make.
Well, we're at the end of our hour. This hour went by really quickly. I could spend another 3 hours with the both of you. So thank you so much for your expertise today, sharing your experiences working with vulnerable and underserved populations. This discussion has been highly informative for me, and I hope for our audience as well. And it really highlights the impact that pharmacy providers can have serving, vulnerable populations and really reducing healthcare gaps and inequities. And specifically advocating and collaborating for the good of all patients, but particularly our underserved and vulnerable populations. Thank you. And I'm going to turn it over to Dave really quick.
Lisa, thank you. Again, I would like to thank Demi, Yolanda, Zal, and Lisa. As Lisa said, this has been a very informative and impactful discussion. I really appreciate it. And Demi and Yolanda, I just want to thank you specifically for your efforts in your community and for sharing your experience and expertise with us tonight. Your work is so very important, and we really appreciate everything you are doing in your community. So thank you again very much. I also want to thank our attendees, including many current and prospective student pharmacists for joining us tonight. That's wonderful that we had such a great turnout of attendees, especially students. That's wonderful. All of our attendees, please keep a lookout for more information from us at the School of Pharmacy. about our next installment in our pharmacy expert webinar series. It'll be later in the spring, and we will keep you informed about that, about what that topic will be. So again, thank you, everyone, and good night, and please try to stay warm. Thank you.
Thank you. Have a good night.